a board member for Harvard Club of the Republic of China. So Dr. Tsai is very involved with the school as well as the ITI and other implant organizations. And this is a great pleasure to have you talk from the periodontist point of view, not just from periodontist point of view, but also from the restorative point of view of clinical challenges and the long-term success of your cases. Thank you, Dr. Tsai.
Okay, thank you, David. It's my great pleasure and privilege to participate in your very successful advanced education in implant dentistry. And it's been a long time, as you said. I've been there a long time ago. So actually, I'm old guard, but anyhow. So I'm very happy to share with you, because everybody's busy, and now I think it's very early morning your time, and also it's late in Asia. So I want to talk about the surgical considerations in implant dentistry and clinical challenges and long-term success. As a periodontist, but also I'm restoring my implant cases. And actually, I think it's very important to secure long-term implant success. So, what's the clinical challenge and what's prospects? And we want to have the predictable implant function aesthetics. So we have to discuss, even though from a periodontist and surgeon point of view, we have to think about the hardware and software. And we have to think about, even though we are doing surgery all the time, but we have to think about the surgical, and also think about how the prosthodontist will restore the case from the beginning, so we can participate or cooperate in this kind of point of view, other than trying to do something which cannot be, or very difficult to be restored, or not easy to be maintained. So the predictable implant functional and aesthetics, we really have to think hard on the hardware. And the hardware involves how to select the implant system and the hard tissue evaluation and treatment plan, and how would you restore the case afterwards. And the software part is called the treatment planning, and how would you treatment plan and put your surgical and process sequence in perspective, and how would you evaluate and augment and treat your soft tissue around the teeth and around the implant, and how would you restore the tissue profile with soft tissue achievement or through the provisionalization, and later on leading to the aesthetic acceptable final prosthesis. So I think that dental implantology is really an interdisciplinary science, and we need to communicate and cooperate, not just among the colleagues and also among with the patients. We have to really know what the patient needs and what the patient wants, what the patient wants to go through, and also what kind of risk factors the patient is willing to take. Not just you want to be a hero, but patient may just want a teeth that can chew, or vice versa. So we need to discuss about the diagnosis and treatment planning. We need to discuss about how we select the case, and how we evaluate the case, and how would you do the treatment plan. And before we proceed with our treatment, we need to think about what's the risk and what kind of prognosis is expected. So we have to assess that first. And then after all this done, then of course we can carry through our treatment plan step by step, carry out through the clinical procedures and our sequence accordingly. And the last but not the least is because the maintenance is always very important. The maintenance didn't come at the end. The maintenance has to, actually the oral hygiene and maintenance and patient's behavior of oral hygiene and maintenance is starting from the beginning, and then carry out all the way through your initial examination, throughout your periodontal evaluation treatment plan, throughout the whole sequence of treatment, and then go into the final process at maintenance phase. And also you have to closely monitor the patient. And currently, I think everybody in the world, we recommend every 3 to 6 months maintenance record is required, I think, to achieve a very nice result periodontically and implant-wise. So let's go into a little bit into how would you predict to have the implant function aesthetics, and treatment plan risk assessment is very important. And risk assessment involves both systemic and local factors. So as a surgeon, we have to look into if the patient has a medical compromise situation, and mostly if the patient can come to your office and attend several procedure or sequence of treatment, they should not be too terminally ill. But on the other hand, most of the patients come with some sort of diabetes or long-term diabetes disease, and some patient has some bone problem, or they are taking some the medicines which is related to the bone turnover. So we have to look into that situation. And also periodontically, if the patient has a periodontal disease, as a periodontitis, of course, we'll treat it, but we have to control it before we go into any kind of advanced or invasive treatment. But also because the patient has that kind of periodontal disease history, then we have to really even more closely monitor the patient throughout the period of the treatment in order to achieve a successful and predictable result. And also, of course, during the period that oral hygiene of the patient is very important, we have to really go through oral hygiene instructions and go through with the patients how they can take care of their teeth before we even do anything into their mouth. And also, of course, the patient very has a bruxism, and I think in Asian countries, I think it's very common. It's also very easy to be ignored. So I think we have to emphasize on the bruxism issue, and a lot of patients really do need a night guard, even during the treatment or at least after the complete treatment is completed. So about 80% of my patients are wearing the night guards after the treatments to safeguard the success. And of course, I think smoking always comes up with risk factors, because no matter for the periodontal disease and also for the peri-implantitis, and also a lot of studies shows that even one of the major group by Lisa Mayfield and Cochrane, and also by the Kausland group, they think that smoking and also involved with the periodontitis and also with the peri-implantitis, and they can see more dramatic radiographic marginal bone loss. The odds ratio is from 2.2 to 10. So the poor oral hygiene, like Lindy Group 12 years ago already pointed out, is one of the major factors, it's the risk factors in implant dentistry. And also history of periodontitis and smoking and diabetes. These are the very common factors, challenges, and we have to really look into the situation carefully before we do any further treatment first. And also, as David mentioned very nicely, I was heavily involved even when I was at Harvard with H.P. Weber. I was introduced to ITI at that moment, so more than 30 years ago. So I was fortunate to be involved in ITI group. It's a very nice academic group. I believe a lot of you are also part of the group. And they publish the treatment guides almost every year for past 12 years. And this is the 10th volume of implant therapy in aesthetic zone. I would recommend you to get a copy, or somebody must have a copy, and take a look. And I will just point some small details into that. So the aesthetic risk factors, you all know, we all know, like how would you, when a patient smile, when you do the surgery, we have to see, especially in the front teeth, how much the gum is showing. But most of the patients, they will show mostly of the papilla, if not so much for the whole gingiva is showing. So I think at least some of the patients, they do show the papilla. So it's more than, some prediction is more than 80 to 90%. When they have a dynamic smile, they really do see some of the, in the middle picture, like a papilla. So most of the patients are more or less in the medium risk group in this category. And also the width of the edentulous span is also one of the surgical perspective you have to look into, because if a patient has ideal space, like 6 to 7 millimeters in the front, it's okay. But if you have less than 6 for lateral incisors, sometimes it's very small. It's also medium risk. But if you have a certain teeth missing, especially like a not symmetrical, like central and lateral incisor, it's very difficult to build in between the implant and the papilla, preserve the bone, and also have a symmetrical result. So that's determined to be high risk group. And if you do have these kind of cases, the inter-implant papilla, most of the studies, will show you like only maybe less than 4 millimeter or 3.5 millimeters of the papilla tissue, soft tissue height can be achieved between the implant. So you create some aesthetic issues in the long run. So we have to be very careful about that. And also, the shape of the tooth also is important, as everybody knows. If the teeth is a bit more rectangular, that means papilla is a bit lower, then it's easier for you to represent or recreate that papilla height. Versus if you have a long triangular shape of teeth, then you have a long papilla, then it's very difficult to recreate that in between the implant or between the implant and the tooth. Also, if the neighboring tooth is restored or non-restored, I think this is controversial. If your neighboring tooth is restored, then maybe if you put the implant in the middle, then you can also prefabricate a provisional crown next to it and to try to create the papilla looks more natural between the teeth and the implant. If the teeth or tooth next to it is not restored, then of course you cannot touch, or you tend not to touch your teeth, then you have to really mimic your implant with the adjacent version tooth or native tooth, then sometimes it's even more difficult. So this low or high risk is really controversial on this point. And also the gingival phenotype, that means how thick your tissue is. Of course, you want the tissue to be thick instead of to be thin. So you want the tissue to be thicker, so you can represent your implant to a nice mimicking the natural teeth. And if the tissue is thin, then it's easy to be receded. And also, if there's an infected site, of course, you have to be careful. And acute infection is a high risk for this matter as well. Also, the gingival height, you have to really look at the tissue. So if you have an intact soft tissue like the picture on your left, then you'll be less worrisome. But if you have a very receded soft tissue in the beginning, before you put the implant, before you take out a tooth, and even not enough adequate keratinoid tissue, that means there may not be bone underneath, then you have to really restore the teeth. Before you restore the implant, you may have to augment the bone, and then they do a staged approach. Otherwise, you have a very aesthetic challenging situation. So we do need the adequate soft tissue. Also, the height of the adjacent tooth is also important. If the bony height of the adjacent tooth is adequate in distance between the height of the adjacent tooth to your predicted or future contact point is 5 mm or less, then as you said, the implant you can predict to create 3.5 to 4 mm of inter-implant inter-teeth tooth or inter-implant papilla, then it should be safe. But if the distance or neighboring tooth is very low in the crystal bone, like 7 mm or more between the bone height and the contact area, then you have the problem in the beginning. Then that's something you have to think, how would you overcome it, and can you try to do it? Or if the other neighboring teeth also has this kind of black triangle, then you'll be safe, because then you're just mimicking more or less the black triangle. And if not, then you may have a problem. Then that's something you have to bring up front with your patient to discuss and to know that before you really jump into it, and to foresee the result and discuss it with your patient. And also, one of the very important things that I think throughout the population is the facial bone height. I think most of people, they have a very thin labial in the front teeth. Labial bone thickness is, most people has less than 1 mm or 1 mm, between 1.5 to 1 mm of the labial bone thickness. So when you take out the tooth, then the bundle bone is resolved, then the bone is going to disappear very quickly. So either you do the immediate implant and graft the bone, or if you have very thin bone, you have a less than 0.5 mm of labial bone, then you might as well take out tooth, just like Boozer group and Chapwick group, they indicated that you may want to have the soft tissue to grow back in 1.5 months to 2 months, and then you open it up, do the implant, do the GBR, and you have adequate soft tissue thickness. Even though you may have lost the labial plate to a certain extent, then you can regraft it back. Other than try to do it all at once, then you may not have not enough soft tissue in the beginning and not enough bone. Then you may wind up in a very bad recession, mid-labial recession. So the thin bony plate, again, you can have a progressive bone resorption pattern as soon as you take out your tooth. And dimensional change mainly occur in the central area of the socket. If you have a healthy neighboring tooth, it may not happen in the interdental side and in the tooth, but it happens in the dental side after you take out tooth in the middle. So like the Stephen Chen and Booza's group also shows that if you have the immediate implant, a lot of challenges you're having long run is you have labial recession more than 1 to 1.5 millimeters, which cause some aesthetic problems. And this is one of my patients to show you that before we try to, we are planning the implant. So in the dentalus side, on the neighboring tooth, you can see very thin labial bone. Oh, sorry. Very thin labial bone. But in between these two teeth, then you can see the dental side. You have very concave, not just thin, but concave and resolved alveolar socket. So if you want to place the implant in the ideal location according to the CT scan, then how would you do it? I think it's impossible. You have to do a stage approach in order to grab the bone and then place the implant in the ideal location. And this is why it's critical in the anterior area when we place the implant. Before we do the implant, we really have to evaluate what's the risk of that. So the aesthetic risk will occur mostly in the facial bone. So the Boozer and Chen group emphasize that in most of the cases, if your bone is less than 1 millimeter of thickness, you might as well do the early implantation, do the type 2, type 3 implant. So you have either upon extraction, stage, grab the bone, or wait for 3 to 4 months, or you simultaneously grab the bone after take out tooth for 1.5 months to 2 months, then grab the bone and put the implant simultaneously. This will be more predictable. So as everybody knows, type 1 through type 4 implant treatment, and most of our cases, including myself or Dr. Boozer indicated, is always type 2 placement. Most like say 80% of all the case, 80 to 85% of all the cases, partial dental cases, fall into this category. Because we need to wait for soft tissue to heal, and still there's enough regeneration potential for the hard tissue in the socket, then there's still partially intact labial alveolar wall, and then we can do the implant and simultaneous GBR. I think this is more predictable, and time frame wise is save patient most of the time. And also we evaluate when you place the implant. After you evaluate that, and when you place the implant, of course, as I said, surgical aspect, you really have to look into the primary stability. I mean, I've been low enough to tell you that sometimes I feel that, okay, maybe this is a case that not as stable as I would like it to, but maybe I want to bury and grab the bone, and then some of the cases I become disappointed, or patient become disappointed. I found that it's not as stable as I wanted to, then we have to redo it. So I think when you put the implant during the surgery, the primary stability is very, very, very important. Then you rely on the bone quality and quantity itself, of course, but also you have to look into the surgical technique. You don't over prep the bone. You really need combine with some special drill or some osteotome to condense the bone and before you put the implants in. And also implant design is also important, but that's not the topic today. And secondary stability, in addition to primary stability, is also the implant surface treatment, and also patient's recipient bed condition is also very important. And I think the primary stability is mechanical, secondary stability also is physiological. And the bone quantity and quality, I think along the time, through when the Lecombe and Zark, they have the characterization of the bone type, and also the Mish and Judy and several other groups, also the 2011, they also categorize the location, the zone of the bone, like a type 1 to type 2 to type 3 zone. and then indicating how bone resorption occurred and how vertical and horizontal bone loss is challenging, and also how soft the bone is in different locations. And before the surgery, then we really have to look into this area carefully and evaluate it very seriously before we go into it, and to see how we can achieve a long-term predictable result. And of course, as I just mentioned, the surgical technique is also important. Don't over drill the bone site. And also the implant design. I mean, again, there are different implant design, more threads, thread pitch, and also the taper and non-tapered, and these are the things that all take into considerations. And also, when you want to load the implant, you really have the insertion torque and also the os tail for the measurements. And also the implant surface, as we have indicated, now is the for the ITI group, I think most famous, as everybody knows, is SLA. SLA is the sandblasted and XAH surface. It's a medium rough surface, and it become in the 90s become the gold standards for most of the imprint. I think nowadays most of the imprint, they have very similar surface treatment to follow, and really carry out the very nice bone augmentation, bone adaptation, also integration, and can really have the loading time, if not immediate, but loading time for like 6 to 8 weeks for regular cases. But again, I have to emphasize, the implant factor itself is still not big enough compared to the physiological factors. So we really have to look into the patient's conditions, other than to use any fancy implant and design and surface treatment, say, okay, whatever it is, I can do a very successful implant in the patient, and with my GBR technique, with my capability, surgical skill, I can achieve a very successful result. Then if you are doing that too aggressively, ignoring patient's condition, then I think you'll be disappointed a lot of time. So I think you have to have a strike a balance between the implant that you chose, and also the technique, and also the patient's condition and the bone condition quality and quantity, in order to get the nice osseointegration and predictable implant success. And I always like to use this case unfortunately nowadays we have to talk to the screen, but anyhow, I like to, if I teach my student, I would like to show some of the pictures that showing them that, okay, if this patient comes to you, okay, if we look into the mouth, look at this, what comes to your mind first? Okay, and the patient should complain that just she feel that old, and maybe she's very choppy, but she still feel old because she has lost of the vertical height and so-called bite collapse. So when you look at this case, as a periodontist, of course, we think, what happened to the two central incisors? Are we going to upper central incisor? Are we going to be able to save it, or are we going to have to extract it, but then will the bone go with it? And of course, the other thing you have to think, can we or can't we do the implant in the edentulous site right away? And of course, obviously, situation like that, you cannot do the implant right away. You have to really see how much vertical and horizontal bone defect you do have, but then you have to have the bite restored before you can evaluate that. Then you even have a higher or bigger vertical discrepancy and to start with. And also the vertical bite collapse, how much is it, and how is the patient's facial profile, and really how can we address the patient's chief complaint. And in this case, I just use it as an example to show you that then we take the impression, mount the cast, and then send to the lab, take the bite, send to the lab, and wax it up, and to see how much we can restore, and in order to restore patient's vertical height and the smile. Then we duplicate that into provisional denture and some kind of overlay, provisional overlay to put on the patient's teeth. Then we can see patient can start from beginning from this, and if we can predictably create her height into these conditions, then the two upper central incisors may be savable, but we don't want to make that kind of decision right away because we want to save the bone. So in the same time, if the two teeth can be saved, not for periodontitis per se, to save the bone, then we would rather save it. And by doing all those, the patient do have a nicer smile, and she didn't feel as aged as she thought, and her employee didn't think that she's as angry as she thought. She didn't like that to be. But this is just the beginning. All the challenges, then you can start from here to think how much risk you have and how much you can restore or you cannot restore to promise back to the patient. So these are the factors, again, in the ITI treatment guides, they tell you what's a high risk group, the gingival biotype, shape of the crown, and the implant interdental bone, and also the width of the dental span, and the soft tissue anatomy, and also the bone anatomy of the alveolar crest, the vertical and horizontal discrepancy. Then it gives you, is it a straightforward case or it is an advanced or complex case. Then even before you really go into the procedure, then you can tell the patient that what kind of a challenge you are going to have, or we are going to work through it, and how much we can do, how much we really cannot achieve, and this is what you have to expect from our treatment. And of course, as I mentioned earlier, the maintenance is also important because the more nowadays, even though again, Lindy's group mentioned that already, more than 12 years ago, they found out that peri-implant mucositis case is escalating, and also peri-implantitis case, which we really hate to treat. And of course, if our patient has that kind of situation, we have to treat it. But we really hate to treat the other friends or colleagues' case. And for some of the cases, then we may send it to David or send it to Jerry to treat. But again, we can know either more than almost a quarter or almost 1/4 or half to the of the patient will experience some sort of peri-implantitis. That means that bone loss combined with the inflammation. And the peri-mucositis is even more. Almost 80% of the patient, 50% of the site will have some sort of peri-implant mucositis, because it's a big number, but we have to think why patients lose their teeth in the beginning. So they lost the bone, they lost the soft tissue, then we try to restore it, but you really cannot restore everything back to the original position. So this is something you have to face and something you have to realize. That's your challenge. How would you control it? That's how, again, every 3 to 6 months frequent recall visit is very, very important. And also it is important because of this kind of high number. The Lisa Mayfield's group and Len's group, they also pointed out very early on in 2014 publications that SPT, supported periodontal therapy, is very, very important in order to ensure long-term implant survival and success. Not just for periodontitis, also for peri-implant mucositis and peri-implantitis. And as we all know, it's showing very clearly on this simple graphs. For the normal teeth, toe tooth, you have the periodontal ligaments, you have inserted collagen fibers, so it also the junction epithelium above that, so it can easily or more easy for you to fight against the infection, the plaque invasion. But for the implant, unfortunately, even though there is still some sort of connective tissue, but it's more or less parallel, so it cannot resist as much of the infection. So I think we have to fight it from the surface, other than let it invade the soft tissue and invade the bone around the implant. Then I think it's very difficult to treat, or very challenging to treat it successfully. And I think, again, part of the initial diagnosis and treatment plan, of course, we have to wax up, as I indicated a little bit earlier. I just showed you through. And the early days, only panel or tomography, and now, of course, we have the CT scan for everyone. But I think sometimes, as an old timer, I think we are taking the CT too many or too frequently, because now a lot of office, they have their own CTs, so they take the CTs beforehand. Even I heard some colleagues saying they take the CTs during the surgery, and of course after the surgery, before the prosthetic treatment, and after prosthetic treatment. I think it's a real overkill. So for myself, I only have the CT for my patient with the diagnosis wax up down and with the CT stent indicating where the teeth is before I take the CT before my surgery. And I don't regularly take the CTs before my prosthetic treatment, or I should say none, or very little. So I may have the later CTs when the patient needs another implant or 2 or 3, like a couple years down the line, then there's a good chance that we send the patient to take another CT. Otherwise, I don't really recall or follow the patient through a CT. That's my own opinion, but I'm just indicating that to share with you. Some people, if take a CT, if they feel fine, that's okay. But really, you have to study the CT to see all the structures. And again, the next, I just want to mention a little bit about what kind of prosthetic, what kind of surgical consideration you should have. I think the implant design is also important because we have to select, as a surgeon, we have to select the implant, what kind of implant we put into the patient's mouth, how long can it last, and we have to pick someone which is have more studies and more reliable. So the implant material is from the beginning of the titanium. Now that there are titanium zirconium, and in some of the company even have a pure zirconium implant, which of course I'm still hesitating to use. But mostly for the thinner or thick, narrow implant nowadays, I will use the titanium zirconium implant instead of pure titanium implant because I do have some 3.3 millimeters implant fractures, even though it's still in single digits, but still it's something that we have to think about. So I will use the titanium zirconium implant other than pure titanium implant, which is 4 or 5 times stronger than the pure titanium implant, especially in a narrow diameter implant, 3.3. But I have none of the implant of 4.1 millimeter or 5 millimeter implant fracture at all. So I think we're confident in that level using the pure titanium implant. And of course, the implant body surface treatment is, of course, is rough surface. Everybody knows based subtraction, addition, or coating, or even the growth factors. Nowadays, the calcium phosphate, is still a lot of studies going on. But mostly nowadays, as I said earlier, is SLA surface, sandblasted, and XC-edge surface, the medium rough surface is mostly the implant used today. And I think it's important, it's from prosthetics, but also I think important the implant abutment connection. Nowadays, mostly it's internal connection. Sorry. But in my times, we started with the early days of Brahma implants, only external hex, external connected implant. And we have to use it. But the more we use it, we found out it's really easy to be loosened. And some of patients, they have a heavy biting force in posterior. They even have a fracture of the abutment screw or of the occlusal screw, if not the implant itself. So mostly nowadays, we all use the internal, internal connected implant. Implant abutment design, of course, nowadays either use conventional abutment or use a K-cam design abutment. Sorry. And for the implant, as I said earlier, we have 2 major types. One is the tissue level, one is the bone level. In early days, the bone level have a flat top, so actually it's not a good idea in today's standards. Nowadays, the bone level is always have the perform switch connection other than the flat top. But as long as you can bring the abutment connection level above the bone to 1.5 to 2 millimeters, you will not have the loss of the bone like the earlier standard bone level implant will occur. And these are just the typical bone level, the tissue level and bone level implant figures. And this is the surface treatment that we just discussed about. And of course, now there are so many different kinds of implants that you can choose from. But again, as I said, I'm not going to mention any implant you should use, but I think, I think you should use the reliable and predictable implant. And again, as I said, the connection of the tissue level is always above the bone. So I use this kind of connection of the implant in posterior area mainly. But for the anterior area, sometimes we need to preserve the bone next to the implant. So we use this kind of bone level implant. And because of the internal connected implant, we have a more taper internal connection. So you have a smaller implant about the micro gaps. That means the bacteria cannot harvest within this area, and it will not create the peri-implant bone loss in the beginning. So, and also you have the platform switch. So you move the horizontal, the offset away from the bone horizontally, so creating a nice biological width without endangering the bone next to the implant. And as I said earlier, this is one of the very early on, one of my first patients. We did the, as you see, we did the sinus GBR with the earlier the Gore-Tex titanium reinforced membrane. Nowadays, of course, I do the sinus grafting. If only for the sinus graft, I don't use this kind of the membrane at all. And then at that time, we only have the DFDBA to use. And I put the implant, put the GBR, and then grab the bone. Half a year later, I find out there's a bone, and put the implant. Then screw retain, and everything looks nice. In this case, I have done this since 24, 25 years ago. But what happened later on, repeatedly, is that the patient always fracture the screw. Sometimes the closer screw, sometimes the abdomen screw. Then we have to replace it quite a few times. Then even though the implant is still okay, you have some bone loss connected to this abdomen fracture. That should be okay. But by replacing so many kind of abundance, then I think it's not acceptable. Even though we change to the titanium screw, still not the ideal solution for that. So for the anterior teeth, as I said earlier, so we have a resolved bone, then most of the cases we'll choose the bone level implant instead of a tissue level implant. So we should be able to preserve during the preparation some of the more critical crestal bone thickness. But that doesn't necessarily mean that only for the anterior area you can only use a bone level implant or platform switch bone level implant. And this is what a few cases that I just showed you again very early on. This is the duplicate from my Kodachrome color slides. You can see the color is a bit, actually not too bad, but it's duplicating from that. And you can see these implants are still tissue level implant. In the very early on days, we don't have a platform switch bone level implants. In lower anterior teeth, the same thing. We have the bone level, the tissue level implant. And this is just one of the clinical case I just show you. We have the tissue level implant, narrow implant, and we grab the bone, use the autograft from the chin. Then we did the provisionalization and copy the shape, molded the tissue, the soft tissue, then can get patient back acceptable, nice result from the severely destructed teeth site. So the treatment plan itself started from when we need to take out the teeth. Then we have to think about, are we going to preserve the bone by bone grafting? But then are we going to delay the procedure? Or we can use some sort of orthodontic alignment, force eruption, to pull the bone, preserve the bone, change the bone angulation a little bit before we take it out, put the implant. And now we're going to place the implant after extraction immediately, or how we're going to do it conventionally. But nonetheless, we have to think, because as soon as the tooth get extracted, the bundle bone is lost, the alveolar bone resorption occurs, then remodeling, and the buccal plate especially is going to disappear, since we have discussed that the buccal plate is very thin. And again, Araju and Lindy's group have very nice, many of this kind of figure, or everybody's familiar with. Along with the teeth extraction, then the bone is resolved gradually, especially the buccal plate and the bundle bone. And the tissue become concaved. And there's no stop of the bone resorption with the implant placement. Okay, it's always the case. Of course, you maybe think they place too big of an implant, so creating more bone loss. But even though if you create the narrow implant, grab the bone, there's no stopping. You can just grab the bone to compensate for the bone loss. So is it predictable? Place implant immediately after teeth extraction. It's always the case, always discussion, always the things that we need to think about. So you have to think about thickness of the late facial bone. You have to think about what kind of existing defect to the facial bone. Is this only perforation, or is it dehiscence? The dehiscence will create more of the aesthetic issue. And how is the tissue biotype? Is a thick tissue, then maybe you should be able to do it. If it's thin tissue, you may think it twice. And also the implant, the positioning is going to be malpositioned, because if you do it immediately, or it's going to be in the right angulation. And nowadays, with the guided implant and also all the pre-implant CTE, every evaluation, you should not be able to place the implant in an awkward position if you are careful. And what kind of biomaterial you use, of course, you have to think about it, and also what kind of surgical and grafting technique you use, and how you're going to immediately load the implant, or you're going to do it conventional loading. These are things you have to think about. And again, this is one of my, again, as I said, as an old timer, I always like to show you the very old cases. This is again my duplicate from my earlier Kodachrome slides. In this patient, when this Mr. Lee came in, he has very bad teeth. Then we went through the periodontal treatment, and we evaluate which tooth cannot be preserved, and also the space we need orthodontic tooth movement to align it, and also correct the bite, and try to restore her occlusion, teeth occlusion. In the same time, we have to take out some of the teeth which is severely inflamed, as you can see some of the X-rays. Then at the early days, then we already think if we don't do anything, then you wind up with very terrible situation that you have a very long implant, very long teeth, and look awkward. So in the very early days, we found that we figured out that we have to do something. So we did graft the extraction site in the very early on days. Then try to keep the bone thickness and the bone height to a certain extent before the implants. And during the same time, the patient is doing the orthodontic tooth movement. In the procedure area, of course, we do the GPR, sinus elevation, then stage approach. And also, of course, for the aesthetic area, we also did some of the tunnel or the lateral pedicle flap to augment the soft tissue. And this X-ray again shows left upper hand. You can see the grafting area. Then we put the implants in, and when you put the implants in, we also graft again. And again, the patient eventually will come like this. It's not perfect, and luckily he didn't really have a huge smile. But again, as I mentioned earlier, his dynamic smile, you can see some of the papilla. But of course, the Asian patient always, when they take pictures, they don't smile too big. You can really take my words for it. You can see some of the papilla. But even though we cannot create most of papilla, still we can create some of the combined natural teeth and implant site, mimicking giving him back acceptable smile and appearance and function. in the early days, we also know the implant placed in a grafted bone, they have a similar success rate as placed into the native bone. So we feel very comfortable in grab the extraction site and put the implant later on and grab it again, and with the same predictable survival rate. And one other cases, again, the lady came in with this kind of awkward situation, and she has been gone through all this so-called temporary raising, bonding, splinting, because she has mobile teeth, and you can see the X-rays. She has a very terrible periodontal disease, but somehow her previous dentist didn't want to do more predictable or more precise work for her. So eventually we have to, again, just like all the case I just showed you, we have to put her through some sort of orthodontic movement, and some of the teeth we have to take it out, and we try to save some of the premolars and molar, and try to grab the sinus, try to grab the extraction site. And take the long story short, because I don't think we have enough time to go through all the detailed procedures. Again, this is not perfect result, but at least we can bring her from this situation from left hand side to the right hand side through the periodontal treatment, put through the extraction and grafting of the extraction site, and also go through all the diagnosis and treatment plan and how to restore her bite and her occlusion and maintenance, and also in addition to the orthodontic, some sort of orthodontic alignment for the remaining teeth. But the whole procedure takes her about 2.5 to 3 years to complete. And now again, as all this kind of patients, she's undergoing every 3 months recall. So again, as I said, so we preserve the hard tissue, soft tissue anatomy as a surgeon. Then we have to think from the moment of tooth extraction. So do we do the immediate or early implantation? As I indicated, most of my cases, I do it in an early implantation. Okay, that means I take out the tooth or teeth and wait for the 6 weeks or 8 weeks, and then we go in and do the implant and GPR. Very few cases we do the immediate implant. Unless the condition is adequate, then the risk is low. That means you have a thick enough labial plate, and the tissue, the teeth is, you have enough angulation is good, and then you can really put the implant in a nice position and graft it in the same time, and even sometimes even do some CDGs. So the immediate procedure in aesthetic zone is a challenging one, and you really have to evaluate that. And also socket wall is the intake, or is dehiscence or perversion. I think dehiscence is most challenging. We're causing some aesthetic challenges. And the buccal wall thickness, again, as I said, mostly in the anterior teeth is very thin. And this is one of the premolar cases. It's not an aesthetic case, but again, as I just want to show you, the patient has a fistula, then we take out the tooth, and after 6 to 8 weeks, still have some fistula, not residual, not heal over soft tissue, but it's okay. Then we open it up, and then we put the implant in the right position, and 2/3 of the implant buccal surface was exposed, but still, we grab the bone and harvest some of the bone. We are taking the Boozer principle. I take some of the graft. We use a bone scraper to cover it first, and then cover with the bios and membrane, cartilage membrane on top to graft it. Then we can achieve or return the patient to a acceptable position and a nice tissue profile. So the patient is very happy and long-lasting result. And the molar is less aesthetic challenge, but nonetheless the bone wall is thick and some of the bone wall is destroyed. Then if you want to do, sometimes we don't do the simultaneous implant because I think we want to grab the bone back. Then we have a nice mesial buccal bone wall back, and then it becomes a very straightforward implant 4 to 6 months later. Then we restore the soft tissue and hard tissue profile with the provisionalization. Then you can remember the patient lost this mesial buccal wall, the implant, restore the tissue. And again, this is sulcization that predicted. So we have to think about how the buccal wall is intact, even in the posterior area, the thickness of buccal wall, and if we can achieve a primary stability of the implant. And for the anterior, again, more challenging area. As a surgeon, we have to think, again, this patient has a very thin tissue. In the beginning, I think it's great. She has a very severe periodontal disease. We have treated. You can see all the black triangle. But for her, when she smiles, she can only see the papilla. So we really have to achieve this papilla morphology back. And these two implants are in the central incisor area. So when I did this patient, luckily that we can preserve 2-1, and then we can take out 1-1 first, and then do the implant, grab the bone, do the polarization, and then take out the 2-1. In the same time, we use 1-1, carry the 2-1 pontic through this healing period. So by doing that, other than take out the 2 central incisors right away, we are successful to achieve some of the small papilla between the implant, which is difficult to achieve. And this is going to the final stage, wax drying. And we compare the provisional crown and the wax crown, and also we want to reshape some of the reticular emergence profile of the wax up crown. So as a surgeon, we still think, evaluate this kind of area and detail, cooperating with the prosthodontic carefully. And by achieving that, then during the provisionalization, then we can really create a papilla, which is not great, but at least you can have from the bone up, you can have through 4 millimeters of a papilla. So it won't have a black triangle between the teeth, and you won't have a square teeth to hide the black triangle. You can see this from the crucial view and from the lateral view. These are the things we try or strive to achieve, but you really have to be careful in the beginning how you plan it. As in this case, we did I did the 2 central incisor implant stagely, other than do 2 implant all at once. I preserve 1 tooth, do the 1-1, and then when the 1-1 implant is restored, then we take out 2-1. Then by doing that, I think we can preserve the bone and the inter-implant tissue. And also, I think, again, as the surgeon, we can do as much, but then I think the prosthodontist has some components has to use. That's a 2-1. Then in the beginning, when the 1-1 case, we don't have the 2 millimeters of the gingival height abutment to use. And when I did the 2-1, luckily now this system has the 2 millimeters of gingival height abutment I can use. I would rather to have the 2 millimeter of the gingival height abutment to use for the 1-1, so I may be able to preserve some more of the inter-implant bone or the inter-implant and the nature tooth bone. So I think the prosthetic component is also very important. It will affect the surgical result as well. And this is another case, early case. The patient came in with the 1-1 missing, the coronary bridge, and we want to have an implant in her, but she has a very narrow or thin labial wall. Then in early days, we take the chin to grab the site and use the old type of the bone screw with the head to screw it, and then to augment the site as a stage approach. You can see the screw head showing through. So now we have a flatter the screw head. And nonetheless, it's as predicted. Then grabbed it, then put it. At that time, luckily, about 10, 11 years ago, we have the bone level implant available. So I was lucky, but not the bone level taper. I would rather to have the bone level taper to be away from the lateral incisor a little bit. But then we use the provisionalization. You can see we try to force the lab to create the emergent profile, really look like natural tooth. Then provisionalization stage. Then try to preserve the inter-implant, inter-tooth papilla. Again, it's not perfect, because if you see the 1 and 2 natural teeth, then this crown is a natural tooth, is a higher papilla than the 1 implant and 1 natural tooth crown. But because in the beginning there's already no teeth, so actually the papilla was not there. But at least we can squeeze a little bit of the morphology out from the patient in the 12 years and 11 years follow up. And again, it's a dynamic smile. A patient always, most 90% of the patient can see the papilla. So that's something you have to be careful in the beginning when you plan the case. If I leave the black triangle here, or I have a very square teeth to hide the black triangle, the patient won't be happy. Again, but in the beginning also I mentioned to her, you won't be able to have a very nice papilla mimicking the 2-1 to 2-2, but still we can create something there. And this is another patient. She has even bigger smile, so she can really the gummy smile. And I follow the same protocol. I take out 1 tooth, put the implant, and then wait for the transition and put the 2-1 in. Take out the 2-1, put it in. So we get to do that because we have in some cases you just cannot do it because the condition doesn't permit you. Then we can create again small papilla in between the 2 implants there. And in the posterior area, also the tissue level, and we also sometimes need to use a bone level implant, so we need to grab a lot of bone. So no matter how, as long as you can preserve, this is the where the bone level is, the red line. The yellow line is where the implant is, implant shoulder is. The white line is where the abutment, crown abutment connection is. As long as I said, as long as you want, I want to mention that as long as you can bring the crown to abutment level, connection level above the bone, at least 1.5 to 2 millimeters, you should be safe. You can have predictably nice bone level, regardless you have the tissue level implant or you have the bone level implant in the posterior area. But not to say that the tissue level implant won't be suitable for the anterior teeth, which these are the things that we only have it available in 20 to 25 years ago. These are, again, the very early cases. And later on, of course, we can have the bone level implant. This is a patient bone level. And the tissue level implant, again, in the beginning, we don't have the bone level implant. As long as you observe the surgical principle and evaluation diagnosis and preserve the bone, as soon as you take out the tooth, grab the bone, try to grab as much as you can, and then put the implant and grab the bone again. You can always preserve some of the inter-implant crystal bone to support your papilla. And with the bone level implant available, of course, you should be more predictable to preserve the neighboring bone because you have the offset of the connection of the abutment, the platform switch should be able to preserve the more bone next to it. And the last but not the least, the surgical considerations is the implant position. Again, everybody know already the famous boozer danger and the comfort zone. And what they say is achieve stable long-term peri-implant tissue level. The implant has to be placed in the correct 3-dimensional position. That means coronal-apically, you cannot put it too deep, but you need a certain depth, 2 to 3 millimeters. For the bone level, maybe 3 to 4 millimeters. Underneath the CEJ or tissue level to create a nice emergence profile. And also mesial distally, you need 1.5 to 2 millimeters next to your neighboring tooth or to the implant, maybe next to implant 3 millimeters at least, to preserve the bone, to create a nice papilla. And also buccolingually, because you cannot have a two. The most difficulties is the patient the doctors put the implant too labially, then it's very difficult to restore the profile. No matter how much you change the angle abutment, it's very, very difficult. So you have to connect the neighboring teeth, the incisor edge, and cervical area. You cannot infringe those kind of danger zone. And these are the collected pictures that I just quickly show you, so you can really think even though this concept was brought up more than 15 years ago, but I think it's still very valid for us to think about, because no matter how many surgeries you do, you will always have to follow this kind of principle in order to preserve enough of the tissue, graft the labial bone into 2, or even nowadays I think 3 millimeter will be better to preserve the labial tissue, then support the labial soft tissue. And maybe later on you also need a soft tissue grafting. But the labial lingual positioning, I think, is the ultimate important situation. And for the prosthodontist, again, the coronal apical position is also very important, because if you place implant too shallowly, then it's very difficult for you to create the nice emergent profile and implant crown aesthetics. And if you infringe those principles, then you wind up with this kind of the situation. And luckily, this is not my case, but I always keep this in my drawer to remind me that don't create this kind of situation. But in this case, actually, can be saved in the beginning if the doctor didn't place the implant as an immediate implant and take out teeth and follow the socket. Then if you look at the profile of the root, actually the root is very oblique into the lingual side. So the doctor follow the socket root angulation and try to correct using the prosthesis of the neighboring teeth, but still cannot. And the patient told me that the situation was worse 1 to 2 months after the surgery. He had a shrinkage of the gum, and then even worse after the prosthesis. So these are the things we really have to keep in mind. The angulation, the 3D angulation dimension of the implant placement is very, very, very important. So again, if we follow all the principles, this is the case I just showed you quickly, we can really, even though tissue level implant in anterior teeth, we can still give the patient an acceptable result and acceptable aesthetic outcomes. So as a surgeon point of view, then we are doing a nice service to the patient. And we preserve some of the papillae, if not too much, maybe, again, as I said, 3.5 millimeters at most in between the implants. And this is another case. The 2 central incisor implant, and again, we can preserve 3.5 to 4 millimeters of inter-implant papillae. So as a surgeon, I think that's at least we should try our best to do. And also, we graft the labial soft tissue, then can have a nice profile and come along with the papillae and the labial profile, and give patient an acceptable aesthetic outcome. But again, I want to use the same patient's mouth to reiterate that in the anterior teeth, not necessarily the tissue level, the bone level implant will perform the best. This is a patient, again, he came in when as a teenager, so we wait until 18 years old to place his missing right central incisor. And that time we still use a TS abutment, that's transversal screw from the lingual screw abutment. And so the patient comes with nice central incisor with nice tissue level implant. They can still stippling of the soft tissue above covering the imprint of the tissue level imprint for a long time. But then later, unfortunately, patient has fallen down have a car accident. So he broke his left central incisor. Then he came for the restoration. Then we placed the left central incisor. At that time, the bone level implant was available, so we placed the bone level implant for him. But surprisingly, to my surprise, is that the soft tissue tone, even though we also did the CTGs for this patient, the soft tissue tone maybe because of the trauma, but partly because I don't know. It didn't really look as good as when we did the implant on the central incisor with a tissue level implant when he was 18 years old. And when I did this implant, he was already early 30s. But it looks okay. But still, I mean, and the reason follow up, and now he's working in China. But nowadays, the last time I saw him 2 years ago, I think the tissue is becoming better and better, but more mature. But again, this is just one of the examples I want to show you. The tissue level implant doesn't necessarily perform not as good as the bone level imprint, even in the anterior area. So finally, I think what I want to emphasize is that the long-term implant success is really very challenging. And we really want to have a predictable implant function aesthetics. So we really do need the evaluation, diagnosis, treatment planning, risk assessment, and carry out the clinical procedures, and later on the maintenance to follow it through. So actually, dental implant is an interdisciplinary science. So really emphasize again the communication and cooperation, and you really have to pay attention to the hardware and software. So treatment cycle, again, reiterate that the diagnosis, case treatment planning, case selection, and we have the procedure of the stage 1 surgery and early implant, immediate implant, early implant, late implant, and with or without bone grafting, and with or without soft tissue grafting, or you do the soft tissue grafting in a stage 2 procedure, and use the professionalization, implant professionalization to model the tissue and try to modulate the tissue to the shape that you want, and the final restoration. So actually, it's a teamwork. Again, we have to have the functional driven implant dentistry, and then we can have a long-term maintenance and success. So again, finally, I want to reiterate my topic today is that we want to have the surgical. This surgical consideration is actually a very broad spectrum, not just the surgery itself. You really have to think from the beginning and to the end, and cooperate with your team. As a surgeon, you really have to cooperate and think before you do anything. Otherwise, nonetheless, you don't want to screw it up. You want to really, as a team player, you want to do whatever you can for the patient and as a team, and for the best benefit of the patient. So the challenge is huge, but I think with nowadays, we are really happy that we can have, after so many years of development. I mean, ever since I was in Boston, I don't think David will know. I don't think I've ever seen the implant has to be sterilized, autoclaved. I don't think I've seen that. I think Jerry also hasn't seen it. No. I saw that. I shipped from Switzerland. Then I asked HP. I said, "What happened to the implant before putting into patient mouth?" He said, "Oh, we have to send to the autoclave." Then I was shocked, but that was the time. But anyhow, this is our timer. But we have witnessed so successful of the development of the implant. I mean, and also because of the development itself, and also the scholars, a professor like David, and in the school and or school, even Taiwan University, they are going to do the research and promote it. I think we are very happy. But again, I have to reiterate: the diagnosis and treatment plan, case selection, evaluation, risk and prognosis assessment before you do anything, and then you carry out through your blueprint, the clinical procedure, and the sequence nicely. Then you really have to maintain your patient very, very closely and follow up. Those are the things I think, hopefully, if nothing else you can remember, I think these are the things you really have to reiterate in your mind over and over again. So thank you all for your very early births or late births in Asia. So thank you again.
Thank you, Dr. Tsai. So it was an amazing presentation, as expected, because you have such a wealth of experience, not just doing the surgical aspect. You studied basically in implant dentistry in the 80s. Yeah, and then also you witnessed how things have evolved from, say, smooth surface, machine surface, to rough surface, tissue level, to the bone level. And it's also very good to see how periodontists can do such a beautiful restoration as well.
Oh, no, thank you.
Yes. Yeah. So from your point of view, I know
Yes.
that you touched upon many points. What is the most important factor that outline here: diagnosis, treatment plan, case selection, risk and prognosis? Among these, if you have to pick one, what would be the most important factor when you treat very complex cases like you have just shown us?
No, I think thank you. This is a very nice question. But I think I would rather pick two other than one. I think the
Yes.
case selection and evaluation actually is coming back to back with the risk and the prognosis assessment. I would think these are the two main factors. If you look into the case, then to treatment plan it. So you really know what kind of outcome you want to predict your outcome as much as possible. So you don't want to be surprised, and the patient didn't want to be surprised, and he didn't want to be surprised in the short term. He didn't want surprise to be in the long term. So I think this is a very good question, but I would say the case selection evaluation, but then the risk and prognosis assessment is really the key to the success.
And I know that many of the even periodontists in Taiwan, they send you the difficult cases because you have a lot of experience. Do you ever reject cases because of the case is difficult?
Now, if it's difficult, I'll send to Jerry.
Okay.
He's much younger than I am. I'm almost semi-retired in my age, right? I'm already more than 60 years old, so I'm reaching my retirement age.
I cannot believe that. Yes. No, and also from the surgical point of view, I know that bone augmentation procedure have been somehow misled by the use of the minimally invasive surgery. How people want to do allow the soft tissue to heal by secondary intention, even putting a color plug over the extraction socket. But you have studied your implant dentistry using non-resorbable membrane, and then with a titanium reinforced membrane. In your hands, what's the most predictable technique to grow the bone?
No, I think again this is a very good question, but I think you really this comes to the case selection. Some of the site actually, luckily we have a very intact wall or just some dehiscence, so then you can really do it very, I would not say minimal invasive, but less invasively. Sometimes you're not elevating the bone, but you can not elevating the flat. You can also do the bone augmentation within the socket and outside the socket wall underneath the periosteum. So then patient will feel very comfortable because you just release the flat or same sort like I would not say submerge the membrane, but without elevating the huge flat. But this goes on very limited cases. A lot of cases you really have to grab the whole site. Yeah. So we'll try to choose. Of course, those kind of cases, the patient is very happy. They didn't really feel much after the surgery. But really, a lot of cases you still need to see the bone. You need to see how it can be augmented because it only goes a long way. If you do that, if you don't do that, then you may come back and haunt you. Especially some of the fresh extraction immediate implant case, because I think in the early days the immediate implant get a not so good name because people try to take out the tooth, but not really grab the bone, just grab within the socket. They didn't forget to grab outside of the socket underneath the periosteum. Then in the long run, you have a huge dehiscence. Then how good is that?
Great. So Dr. Tsai, thank you so much for staying late tonight to give an amazing presentation.
Thank you very much. It's my pleasure.
Yes, also we'd like to thank all the CE participants for staying up late. Just wanted to remind everyone that next week we are not having a course because there's an AAP periodontology meeting in Miami. So we'll convene again on November 13th, the Saturday. And that will be on CAD/CAM implant dentistry. So yes, and Dr. Jennifer Chen, she's a faculty member at our school. She'll be presenting the topic on 3D technology in paradigms and implant dentistry. And Dr. Yonghang Fu, he's also oral surgeon and then a part-time instructor at our school. He's going to be presenting on digitally guided complex hard and soft tissue augmentation procedure. Thank you, everyone. And then I know it's late at night, and have a good night. And we'll see you in 2 weeks. Thank you.
Thank you, David. Take
Okay,
care.
thank you, Dr. Tsai.
Thank you.
Thank you,
Thank
Dr.
you, everyone.
Vidal. Okay.
Bye.
Bye.